And they always show a nice picture of a very depressed woman in the shadows here.
I thought I put it in.
And they go on to say that major depressive disorder is the #1 contributor to disability worldwide. I thought it was #2. #1, disability. Not heart disease, not cancer. It's a common illness, 16 million adults, at least. And they show us this nice data, these studies of why we should use their drug. And significant, that's their word, reductions in symptoms versus a placebo were achieved in major depressive disorder with a mean baseline score of 36. Okay, they use a depression score like the one I told you, with this questionnaire. How depressed are you? You answer all these questions. You can go from 60 down to 0. 0 means you're really good shape, you don't have any problems. Nobody lives at 0, of course. 60 is really bad. So these people, 36, they're kind of moderate depression area. And then they give them the drug for how long? We find out here when they do this that this was about an 8-week study. 6 or 8 weeks. So that's all they did this for. And then they summarize with the graphs how many points difference with 40 milligrams of their drug, 80 and 120. Gee, if you give them 40, there's a 3-point difference on the score. Remember, this score goes up to 60. So 3-point difference. If you give them 80 milligrams, there's a 4-point difference. And if you give them 5-point at 120, but look what placebo does. So basically, here's the improvement from baseline, 41, 43, 46, but placebo does 33. Okay, so keep that in mind. Then they show it in another graph form, going out here 1 week, 2 weeks, 3 weeks, and here's placebo, and better is down, so the drug's showing a little improvement. But 8 weeks is the trial. Nope. Now, they say, I love this, the exact mechanism of the antidepressant action is unknown. But it's thought to be related to potentiation of serotonin and norepinephrine in the central nervous system through inhibition of reuptake. So they show you a nice graph of norepinephrine and serotonin and the chemistry here, but you don't have to know that, but just remember that, what they just said about, they don't know how it works. And then if you take this, this is what you look like. Yeah, indeed. I mean, this is pretty cool stuff. Here's another one. Jim?
Back to slide, it said relieves the symptoms of depression, does not, so it's curing the symptom, not the problem.
Ah, that's Jim's question was, it said it's changing the symptoms, but not necessarily changing the problem. Hold that thought, and we'll work on that some more. Another advertisement. Is this what Johnny's mom is like? Empty refrigerator. I don't know why they put that on. It's pretty neat. And again, they do the same type stuff with us here. But here they do 6 studies. Wow. Well, the colored ones are their drugs, and the black is the placebo. And 5 studies. And you can see the placebo does pretty good. Or pretty well. And now, what about this drug? Mechanism of action. Mechanism of antidepressant effect is not fully understood. Check the verbiage, not fully understood. But it's thought to be related to its enhancements. But now, I told you there was these serotonin, that there's serotonin receptors. Well, I said there's at least 15. And it says, well, it works on this one, this one, this one, this one, this one, but we really don't know. Yeah, so studies show that on these receptors, yeah, we don't know what it's doing on those. So this is their, and this is to the physicians, this is what they're writing to us. Another one, fibrin. 4 studies. And this time they did 4 placebo-controlled, 8-week studies, 2 8-week studies. And then they followed it for a year after. We'll talk about what studies, how important they are or not. more than 2 million prescriptions filled, and available to branded copay in many managed cares. So they're telling you, hey, we got this new drug, and we don't care what insurance plan you got, we're the lowest copay, so you have to pay the less. Insurance company will do that. But there were a few patients over 65, so some of you, sorry. They'll still prescribe it for you, but they didn't do any studies in people over 65. In 8 weeks. Not a long while. And again, they show their graphs, but look at this. They say 57% improvement from baseline in this scale. But the placebo was 47. That's a pretty good placebo. Somebody in the room told me, if it's a placebo, it's making me feel good and happy. I don't care. Well, it's the placebo effect of the drug, except of course the cost, right? And down here, the efficacy of Vibrant has not been systematically studied beyond 8 weeks. Think about that. And they want you to take this stuff for long periods of time. Minimum of 6 months. It's always first major depressive disorder, a year for longer. So they want you to take this stuff for longer, but they're not studied whether it works well after that many weeks. Oh, what does our Academy of Family Practice and our journal say? Well, last year they said, let's take a look at this. Said it's not been studied in patients who have mild or moderate depression. It was only studied in people with moderate to severe. Well, wait a minute. A lot of the people we see are people that have mild or moderate. And they're just saying, no, they just use this for severe depression. And their conclusion, bottom line, the evidence does not support the use of this in the treatment of depression. It's significantly more expensive than generics, $150 a month versus 10 for amitriptyline and 17 for Zoloft. More expensive and no more effective to moderate or severe depression than other ones that we have or the older drugs. So basically, all the data has shown that these old drugs we've had around for 20, 30, 40 years, all the new ones, they all work about the same. No matter what spin they want to put on there, it's about the same. About 30 to 40% is the average. And also, they said the safety is a small study of 1 year. They did one follow-up, but don't prescribe this until more research says it's going to be safe long-term. How do you know what the safety of this is going to be long-term? Another publication that I've taken is the Bible that I like, the medical letter on drugs and therapeutics. This is for physicians, and they tell us what things that they evaluate the drugs and then kind of do their bottom line. So they did both these two drugs, the Brintellix and the Vibrant, and what did they have to say? It's new, multimode activity, not been demonstrated clinically. How it compares to other antidepressants in efficacy or side effects, including sexual dysfunction, waking, I don't know, remains to be established. And its long-term safety is unknown. Until more data becomes available, other antidepressants should be preferred.
Who writes the letter? Who writes your medical letter?
A whole panel, the question was who writes the medical letter? It's a whole group of independent physicians who have no pressure from anything. They're very, very conservative. New drug comes out, it better show awful good in any area, whether it's blood pressure or whatever. That's their typical response. This stuff costs more, there's no data that shows it's any better, and we don't know the safety of it. I'd say 95% of that. Okay, what's the problem with depression? 70% of patients with major depressive disease were non-responders or partial responders.
Responders to what?
To the antidepressant drug. So you give these people the drugs, 70% don't get really well, or they get partially well. That's just the data. 90% of patients report moderate to severe levels of functional impairment. It's screwing their life up. So this isn't just the, well, I feel a little bad today. It's having significant functional problems with them. Now, all depression is not the same. There's different kinds of depression, which we can't go all into, but there's some depression where people are really anxious and depressed, and some where they're just depressed. And doctors basically have, and I'm going to talk about anxiety in a minute, but basically, you got two choices. You can switch or you can augment. So I had somebody, they're not getting better, they're on their antidepressant, I'll switch them. I'll switch them to Zoloft, or I'll switch them to Effexor, or try one of the other ones. Because they got about a 50% chance that they'll work. So switch them. But, gee, if they're anxious, they ain't going to do so well. Only about 10% are going to get remission. If they're not anxious, depressed, maybe up to 34% with this drug. If I put them on Zoloft, the non-anxious people, maybe a little under 30%, but the anxious people, not too well. So, you see the difference, and all depression isn't the same. If you're anxious and depressed, it's a lot worse. Now, the other strategy you can do is augment. You stay on the antidepressant you're on, and we just got to give you another drug. So we're going to augment it. So we'll put some bupropion, which is called Wellbutrin, or some buspirone, which is Buspar, and we'll see what happens to them. Well, it helps a little bit on anxiety, people, but about 35%. So remember that, switch or augment. Now, what about anxiety? On here, remember our continuum? We got depression way down here. We agree that depression is down on the bad end. But let's put anxiety in here, because that's on the sad and less happy part of our scale, right? Are any of you ever anxious? What about anxiety? Is it a disease, or is it just worrying too much? Do we learn it from our parents? Is it genetically based? How do doctors in the medical establishment define and categorize anxiety? Why did it evolutionarily develop? What does it have to do? How can we treat it? And does it overlap with depression? I think we've all had this look at one time or another. Definition. It's normal to feel anxious from time to time, especially when your life is stressful. However, severe ongoing anxiety that interferes with daily activities may be a sign of a generalized anxiety disorder. You can develop this as a child or as an adult. It's got similar symptoms as panic, obsessive compulsive disorders, and other types of anxiety, but they're different. So as doctors, we said there's just general anxiety, but there's maybe social phobia, you're afraid to go to school or with other people, or agoraphobia, afraid to be out in crowds. So there are specific things you can have anxiety over, but this is the general stuff. And the problem, it's a long-term challenge. In many cases, it occurs with other mood disorders. In most cases, it improves with medications, we'll see about that, or psychological counseling. So in the old days, you took methylphenidate, you took Valium, and it makes your anxiety better, okay, for short term. So what are the symptoms for the Mayo Clinic staff? Worrying, obsessing about small or large concerns. Kind of normal to obsess about large concerns, I think. The small ones, feeling keyed up, fatigue, difficulty concentrating. Oh, your mind going blank. Irritability, muscle tension, trembling, trouble sleeping, sweating, nausea, diarrhea, shortness of breath, a rapid heartbeat. So you can have these, and the times when your worries don't consume you, but you still feel anxious, well, there's no reason. You might worry about the safety of your loved ones or you, or have a general sense that something bad is going to happen. Our DSM-4 book 5 just came out. This is which did not change, 4 to 5, so this is the definition of depression. Excessive worry and anxiety occurring more days than not for at least 6 months about a number of events or activities, work, school, doesn't care what. The person finds it difficult to control the worry, and the anxiety and worry are associated with 3 or more of these symptoms. So you have A and B and 3 of these things: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, or sleep disturbance. But for a kid, they only have to have 1 of these to be diagnosed with anxiety disorder. And I got a problem with that. And the focus of anxiety is not just the one feature. So it isn't just fear of snakes. It isn't just one, a specific type thing. And the symptoms compare. They're no fun. Okay. They did an interesting experiment where they took 10 volunteers and they hooked them up to IVs. And they just sat there, they videotaped them and watched them, and they said, we're just going to run this IV in and just tell us what you feel. And they ran this IV in, and what it was sodium lactate. It's a chemical our body makes. And they ran sodium lactate in them, and after about 2 or 3 minutes, some of the people started looking a little fidgety, their eyes kind of opened wider, and they're kind of shuffling around in their seat, and they're starting to get a little panic look on them. And they're video. So about 4 people out of 10 are having an acute anxiety attack from sodium lactate. They don't know what it is. Because the other people are sitting there like, well, this is an interesting experiment I'm getting paid for, But this shows that there's a biochemical effect going on in some of these people that's causing this, the sodium lactate. So they're chemically primed to have it. So I'm just showing the biological base. It isn't all I'm just worried because my mama was worried and stuff like this. There's a biochemical basis to some people for their anxiety. Evolutionary advantage. Why do we have anxiety? I'm going to talk later about why we have emotions, depression. And this Thomas Weir, not related to Dr. Weir, says the members of the species who were too anxious to deal with crowds, who didn't go to high places, didn't enter tunnels, didn't single themselves out from the rest of the crowd, kind of stayed over on the side, shied away from strangers, went home when they sensed danger, probably lived longer and had lots of babies. I don't know, but that's a pretty strong biological imperative. If there's trouble and you just kind of shying away from it, you're more likely to not get in trouble and have kids and reproduce. Is that right or wrong? So I'm telling you, there's a biological reason. It's kind of programmed in us. So to be anxious isn't necessarily. The problem is in our modern society, we get anxious over the wrong stuff. But I want you to see there's an imperative. This is why this is programmed into our brains. Anxiety in some form or another. This is the overlap, big, huge Swedish study of depression, anxiety, and depression. Look what the percent overlap is. It's huge. Yes, there's some people that just have anxiety, and some people that just have depression, but the majority have it. Over 50%. So if you're depressed, 50% of people are going to have major anxiety. So you better think about it or deal with it or realize it's going to be there. And if you're anxious, the chances of you getting depressed are over 7 times normal. So if you're just an anxious person, the chance of you crossing over into here, that's I think, significant. Social anxiety disorder. We can find out where it is in the brain now, which I think is kind of cool. And they did a brain scan to predict the outcome of therapy. Patients with social phobia, they're afraid of groups and people, whose brains lit up the most, that's this side, particularly towards the back of the brain, that processes what we see. If you had a brain that looked like this, you'd respond better to psychotherapy than you would to drugs for your social anxiety. If you have math anxiety, raise your hand. Good. Math anxiety. So we're going to have the math test, folks, here, and get your pencils out of your slide rules. I guess I don't do those anymore. Math anxiety. Okay. Well, I'm here to tell you that science to the rescue. They took these subjects and they gave them a math anxiety rating scale. They said, how excited are you about math tests? And they rated it. And then they took the people that were really, they don't like They have a lot of math anxiety, and they said, can we image your brain? And they did. And guess what they found? There is a spot in the brain that has to do with math anxiety. Biologically, they can see it. So it isn't when you were taught something, there's a spot in there. And they can tell you definitely where it is. So doesn't that make you feel better now that you got a spot for your math anxiety? Okay, getting back to our depression. Proportion of responders who had symptoms that persisted after they were treated at the exit of these studies from the Journal of Psychiatry, 2013. This is not old data. So people, 70% after they're treated, still had suicidal ideation. 40% still had a negative self-view. Low energy, 66%. Sad mood, still 70% after treatment. Mid-nocturnal insomnia, waking up in the middle of the night. 80%.
Is that medical?
This is after you are being treated
By drugs or psych?
by drugs. Thank you. The question was after being treated with what? With drugs. Because this is what most of the psychiatry is.
Did they ever do anything with wine and beer?
Did they do anything with wine and beer in the studies? No. Good study. If you get some money for that, you can probably do that. Oh, back up. So, Abilify to the rescue. Pharmaceutical, big pharma here. After 6 weeks on an antidepressant, I was still struggling with my depression. She's got this big chain ball that she's carrying around. People do not get better on antidepressants, usually because they don't take them. They don't take them long enough. The doctor doesn't give them the high enough dose, or they don't titrate to the high enough dose. So when someone's failing a treatment, it isn't necessarily because the drug isn't working. The patient didn't take it, they had side effects, they didn't get to the highest dose, or they didn't take it long enough. It may take 6 or 12 weeks or longer. So you need to be aware of that. But, drug company to the rescue, and free trial offer. Oh, let's find out why that's important. And here's their helpful physician, treating depression. Pulling you out of your hole. How do you like that? I love that image. It's just so cool. Can't make this stuff up. Mechanism of action. Well, let's see what this Abilify does. Well, they use it to treat schizophrenia, bipolar disorder, autism. But the mechanism of action of aripiprazole is unknown. So they treat it for all this stuff, but the mechanism is unknown. And psychodynamics, it's got all these receptor stuff, which we don't need to concern with. But key thing is they're saying in their own drug stuff, we don't know all this stuff, how this stuff works. And they say, well, people have a high remission rate. When they get depressed, they get better, but then they tend to slip back into it later. And if you use a placebo, proportion with relapse, and the placebo, after 364 days, 25% of people are going to relapse again. They'll get their depression back. But if you give them this Abilify, only maybe 15% are going to relapse. That's interesting, but are you still, have I convinced you, do you want to take it? Well, you need to know this that I just told about. Once you have a depression, there's 50% of those who recover from a first depression will have a second one in their lifetime. If you had 2 episodes of depression, 80% of you or a person is likely to get it again. And if you have 3, what are the chances you're going to get it again? It just goes up. That's just data. We're going to have to find why later. So that's kind of important. Now, let's go back. I forgot to tell on Abilify. Susie, we called up the pharmacy yesterday for Abilify, the dose of a 1-month supply. Did you look it up or did you want to take some guesses?
How much?
How much it costs? A month's supply. Just 1 month. 30 days, 1 month supply of Abilify 5 milligrams. 300.
$3,000.
$900. Now, if you took the Vibrid before, that's $200. And you go to see your doctor and he says, well, I'm going to use some Abilify to augment. And you go to your pharmacy, well, if you don't have your free coupon, we double checked with the pharmacy lady at Hy-Vee. We said, excuse me, how much? $900. So now you got $1,100. How are you going to feel now with your depression? And who's going to be able to afford that? Only the rich. Who's got that kind of money that they're going to throw around for their depression? And what are the chances of it working? And safety and long-term wise. 5 minutes or 5 minutes? So what do you think? Do you think we have a good model for the cause and treatment of depression? Are you buying into this neurotransmitter? I mean, it doesn't seem to do too well. Yes, in the back.
You're asking two questions.
Yes.
A good model and treatment. The model still can be valid, but the treatment modalities are not right yet.
Good. The two questions are, one, the model could be bad, and two, the model could be okay, but the treatment's just crappy. And I tend to agree. But on the second thing, they've been playing with these antidepressant chemicals for 30, 40 years, with the Elavils, the amitriptylines, and they keep mucking around and changing the molecules and doing the stuff and doing long trials, and they still come up with this about 30 to 35% that these different drugs work. And it doesn't seem to make a difference which one it does. The relapse rate, so the data seems to not change much. So my hypothesis is this model, and it doesn't explain 70%. So any model that explains in physics, Bird will tell you, it only explains 30 or 40% of the phenomena, and oh well, it doesn't explain the rest of it. I mean, I don't like that for a model. Yes?
If we have someone who has cancer and you say you have a 30% chance of saving your life with this treatment, and you approach depression as a potentially fatal condition, you have a choice of taking this now and hopefully saving this person's life at a 30% chance. People are going to take it, aren't they?
The question is, if you had cancer and you had a 30% chance of saving your life, people would take that. And that's a very good point, because when you're down here at the end here, and you're close to suicide or depression, it is fatal. Suicide is high rate. So those people, yeah. So one of the sub-points I'm going to make here is some people who are on antidepressant medicine should stay on it. Some people who have had major recurrent problems with it after 2 or 3 times, gee, you're going to relapse. Why don't you stay on it, even if it gives you a 30% chance that you're not going to relapse? And when we talk later, I'm going to talk about ECT therapy. How many of you would want to have ECT therapy, electroshock therapy, for depression? And the answer is, somebody raised their hand, and 2. The 2 knowledgeable folks in the back room.
It would be a good experience. It would be interesting.
And not for you to be interested, but we'll talk about that. But that gets to the point that ECT is very effective. Its effective rate is 70 to 90%. And it lasts, it goes into effect within 1 to 2 weeks. And the side effect is, some people, memory loss, the book I gave on the broken brain, she said it doesn't cause memory loss. She's absolutely wrong. It does in some people. Some people it doesn't. But ECT, so if you're really bad, you go in ECT that lasts to induce a seizure. We'll talk about it a little more, but overview now is they use anesthesia. It's not like one flew over the cuckoo's nest. And it can be done as outpatient. They apply it to the temporal area of the brain, and we'll talk about why later. And they use about a 100-watt bulb amount of energy, because they need that to get through the skull. So a little bit of it gets in there, creates a seizure in the frontal areas. Sometimes they do it unilateral, sometimes bilateral. They found unilateral was just as good as bilateral. 30 seconds, a minute seizure, but they got a muscle relaxant, so you're not shaking. Do anything. You wake up, you're kind of groggy, they keep you for a little while, and you could go home. You get a series of 2, 3, 5, 7, or 8. So ECT is absolutely, shows the best efficacy, and a lot of people who have been through major stuff would say, give me ECT. I have one of my patients who's a professional in the community, and he's at ECT dozen times. He doesn't want to wait around 6 weeks and play with some drug that might work or not work. He knows the ECT is working.
How does it compare cost-wise?
How does it compare cost-wise? Depends what your insurance is. I mean, literally, it does. Okay, so let's leave us with this. You guys can think about that, and we'll come back after break.
Thank you for taking your when we first, the planning committee first asked Dr. Paulson to do a correspondence, he said that he could probably do this topic in 3 classes. And we told him that he had to do 4 classes because he never gets done 3 classes anyway. Well, now he is asked if he could have 5 classes. And the planning committee said he could, and it's all right with you folks. Is it okay with you? We will add 1 class onto the normal schedule that you have. And here to continue with the 3rd class is Dr. J.R. Paulson.
Thank you. Well, thank you. You get more for your money. Question?
I do not appreciate your snarky attitude towards these drugs. I have seen them help too many people.
Very good question. Let's talk about that right now. My wife came up and corrected me on that also. So your spouse is always so good. Now, I tend to do in, the question was, she didn't appreciate my snarky attitude toward the drugs. And yes, I'm using hyperbole to try to overmake the point. Now, the 30% that it works for, those people is really important. And as I said, I'll re-emphasize again. Some of these drugs are absolutely life-saving. And I mean not just quote life-saving, I mean are. I've had many patients that have been suicidal attempts and come out and have tried again, but they get on the right combination and they're not suicidal anymore. It does work for those people. But I'm saying as a model and saying for everybody, no. So again, the key thing we're going to find out in the class, and I'm going to show you with the other, I'm going to have a model. The model that I'm going to use is called holistic. And it's going to say, yes, we have a biochemical component. Yes, we have a genetic component. We have a social component. We have a psychiatric component, what we think of ourselves. And we have a spiritual component. And if you don't deal with all those, you're going to be missing some things in a lot of people. And that the best is to use a model of more. Now the data shows that if you treat people with drugs or medications or ECT or stuff, most of it, under 50% improvement. If you use psychotherapy with a good psychotherapist, and that's a big if, but there's therapy and there's cognitive behavioral therapy, and it's only as good as the therapist, in my opinion. It's been shown, doesn't mean what type of they use, but if they're good and they jive with you, a little bit under 50% can be improved. But if you use both psychotherapy or cognitive behavioral therapy and medication, then you can get up to almost 70% improvement. Oh, how interesting is that? And I'm going to show now why our society isn't into that or doesn't want to do that. So that's a great lead-in. Yes, question?
You didn't mention nutritional. Does that fit into one of your other categories, or how does that?
Nutrition, sleep, exercise are all going to be revisited. The question is whether I didn't mention anything about nutrition. That's going to come back in later when I give you the way that we can improve our mental health. Nutrition will be one of the things. Okay, picture of a brain. This is in my Michigan State medical magazine that I got. And there's a picture of a professor who studying suicide and found higher suicide rates with a parasite. And you go, wow, that's interesting. Well, what does she say about this? The preferred treatment for depression is effective in only about half of the patients. I told you it's probably less, but let's give her half. That's because in many cases, the class of antidepressants known as SSRIs likely target the wrong brain chemical, according to a study by her, psychiatrist and professor of Michigan State. She said this is a departure from decades of controversial wisdom in psychiatry, that the SSRIs, serotonin reuptake inhibitors, we're just going to call them that, long the preferred treatment for depression, are believed to help about half the patients by increasing the serotonin. She says our findings suggest another neurotransmitter called glutamate, and that's really important. And they did a study and found high levels of this quinolonic acid in the spinal fluid of suicidal patients. And this quinolonic acid increases the signal strength of glutamate, an important brain neurotransmitter. So she's saying, oh no, we found this other transmitter, maybe this is important. And they find suicidal people and either have committed suicide or have done it and are still alive because their spinal fluid changes. Another study that she published last July between an association between attempted suicide and an infection of a parasite called Toxoplasma gondii. This is a parasite known to cause mild flu-like illnesses in people, particularly dangerous for pregnant women. Cats are the host for this. Between 10 and 15% of people born in this country are believed to carry this. So a lot of you have Toxoplasma gondii in you. And she examined 100 people in Sweden, including 2/3 admitted to hospitals for suicide. The parasite was found 7 times more likely in the people that attempted suicide. 7 times. So they looked at their brain. And she also said that this causes an inflammation in the brain. And the parasite causes a gene that increases the dopamine, another transmitter in the brain. And in healthy brains, dopamine regulates movement and emotional response. But in depressed patients, changes in dopamine production may cause impulsivity, including suicidal attempts. So, conclusion or findings suggest that not all depressed patients should be treated the same. Someone's thinking outside the box, that it isn't just about SSRIs, just give them this drug and get another SSRI drug, and we're going to, which is what the pharmaceutical companies are working on doing. So, do we RX too often? Other patients that really don't need the antidepressant drugs? Are we promoting happiness with a pill? Are we doing more harm than good? Who should and who should not get an RX for an antidepressant? For many people, these drugs are literally a lifesaver. But which ones? Mental wellness. Percentage of non-elderly who use antidepressants has gone way up. And the increase in using antidepressants is regardless of gender, age, marital status, education level, and health insurance status. So that's interesting. I don't believe that, but... So the question is, there's increased antidepressant use, but it's unclear if more Americans are really struggling with mental health issues. And we're accepting it socially now, discussing and treating depression. And we're also using antidepressants for things like insomnia and back pain. Now, I know as physicians, we don't want to admit that we're depressed. And so we have the social stigma because we don't want our colleagues to know it, we don't want it in our medical chart, we don't want the insurance company to know it. Because bad things can happen when we make a mistake and, oh, you were this. So the physicians that I treat that have depression, it's done surreptitiously usually. Very few doctors are going to say, oh, I don't have depression, or I do have depression and I'm being treated. So we may talk one thing and do something else. Now, heightened misawareness of certain drugs may be another explanation. How about the pharmaceutical, direct consumer advertising? Yeah. A study in JAMA, the Journal of the American Medical Association found 55% of participants who requested a brand name drug received an antidepressant, but only 10% of patients who had similar symptoms similar symptoms, but made no request, received an antidepressant.
Wow.
So when you go and say, my doctor, I saw on TV, or my doctor wants, ask your doctor about Zoloft or Paxil, one of these things, look, you can't argue with that statistic. And doctors, we're not influenced by that, but what patients are doing. Also, fewer patients are seeing psychotherapists to resolve their mental health problems. So, if less people are going to psychotherapists, what's going to be the default strategy? Busy slide, but basically, lower clinician reimbursement rates for psychotherapy and higher out-of-pocket costs most likely contribute to the declining use of therapy. Antidepressants are overprescribed and underprescribed in the United States. As Paulson said, many adults with major depressive disorders go for long periods of time without receiving treatment. But at the same time, many people with mild depression are prescribed antidepressants, even though they're unlikely to benefit from them, whatever. So we got these people that aren't getting treated and these people that are. I like this one. Good example. This doctor tells the story of a woman who didn't like the way her husband was handling the family finances. She wanted to start keeping the books herself, but didn't want to insult her husband. Doctor suggested she try an antidepressant to make her feel better. Don't confront your husband. Take this Prozac. So she did. She got the antidepressant. She did feel better. She wasn't obsessing about it all the time. But, meantime, husband left the family in the financial ruin. They were bankrupt. Doctors are now medicating unhappiness. Too many people take drugs when they really need to make changes in their life. Put an asterisk by that. We're going to come back to that. Now, the psychiatrists, they see it's great. We're getting more depression. It's a public health issue, yes. More people getting treatment, that's good. It's going to be 25% of the whole population is going to have depression at some time. That is a huge marker. 25%. And 8% of adolescents. Dr. Poster says that genuine depression is driving the prescription numbers. There's more depression. I think there's something to that. We'll talk about that in the next class. But this internist says, nah, the real force is pharmaceutical marketing to consumers. Put those two together and you got a lot. He said he questions whether all those prescriptions are necessary. It's hard to believe that the number of people are depressed or that antidepressants are the answer. Now, I'm a scientist. I try to use a scientific brain, and I want data. So the FDA in 2008, there was a dozen antidepressants, and there were 74 studies. They found that most studies with negative results were not published in the scientific literature. Wait a minute. Or were published in a way that had conveyed a positive outcome. They were bad, but they put a spin on it to make them sound good. Holy cow. That's not good. The FDA showed that half of the drug trials had positive results, 50-50, flip a coin, but 94% of the trials cited in the literature were positive. In pictorial form, according in antidepressant trials. Talk about antidepressants here. So, all data, how effective they are. Published data, gee, unpublished data down here. So, the companies, stuff that doesn't work, or they go 8 weeks and then their drug tails down, they're not going to publish it past 8 weeks. They're going to show in 8 weeks, studies showed the stuff was great. Or they do some studies that didn't work, they're not going to publish that. That's the way the United States is. If you're in Sweden, you have to publish all of the studies. All of the negative ones. So this has to do from country to country. How many countries in the world have direct advertising on TV to patients? 2. The United States and New Zealand are the only ones. George was there. Did you see any on drug advertisements or not?
I didn't, but I didn't have much time to watch.
Okay, hopefully you weren't watching TV there. But that's 2. Nobody else is going to do that. What about suicide and treatment? Well, you got ideation or behavior, suicide attempts. That's pretty important. Well, let's give people antidepressants, or let's give them placebo and see which does better on suicide. We're not talking just feeling bad, we're talking suicide. And if an antidepressant does better, the studies go this way. If a placebo does better, they go that way. Well, if you're greater than 65, antidepressant probably keeps you thinking less about suicide and your behavior is better. All adults, just a tiny bit better. And in this age group, 25, 30, it's but look in kids, 18 to 24, and look in children. In other words, you're more likely to have suicidal thoughts if you're on an antidepressant. Hence, the black box warning that has on all of the warnings, suicidality in children and adults. Antidepressants increase the risk of suicidal thinking and behavior in short-term studies. So, you have to be thinking about that. I do not prescribe antidepressants in kids. I'll let somebody else do that. Big Pharma. This is classic. I just love this. See if you like it as much as I do. Big Pharma to redefine depression in Japan. In his book, Crazy Like Us, The Globalization of the American Psyche, this journalist, Ethan Waters, describes a disturbing account of how American psychiatric concepts are displacing traditional cultural views of mental health and illness. So recently, the psychiatric term for depression in Japan was, anybody know Japanese? Utsubio, whatever. And that is, in their language, a mental illness as chronic and devastating as schizophrenia that makes it impossible to hold a job or anything like a normal life and requires long-term hospitalization. So does anybody want to have Utsubio? No. If it's an uncommon disorder, a lot of people don't have this in Japan. And it's surrounded by serious social stigma. So if you mention that or some of your family's got that, you feel sorry for them, that's bad. This situation did not offer pharmaceutical companies many opportunities for profit. I mean, how are you going to go there and say, you know, here's some drugs for this? Wow. So, as Andrew Weil, one of my favorite people, and I'm going to use his book for reference later too, describes in his book, Spontaneous Happiness, the drug companies created a need based on a new perceived disease. So GlaxoSmithKline, makers of Paxil, began to promote the idea that depression should be renamed. So they said, we're going to call it not depression, Kokoro no Kazi, meaning something like a cold of the heart-mind. So we're not going to use this other word, we're going to use this term. Now, the new name accomplished 3 things. 1, it implied that depression was not a severe condition and so should not carry a social stigma. 2, it suggested that treating depression should be as simple as taking a medication for a cold. And 3, it indicated that just like everyone gets colds from time to time, so does everyone get a little depressed now and then. So you changed the term. Now, did it work? The fact that direct-to-consumer advertising is illegal in Japan was no obstacle. They instead published the notion in public service announcements. So they flooded all of Japan with these public service announcements about this condition. TV, books, and magazines. Result, 2000, the sale of Paxil was 100 million, but by 2008, it was over $1 billion. They convinced all these Japanese people and doctors that you have this disease, and we have just the need to the treatment for that. Do you remember Voltaire's quote? I do. for drugs of which they know little, for diseases which they know far less, and to patients for whom they know nothing. That's a little cynical, but just want to keep that in mind here. I think we can now agree that the simple model of depression, the simple model is a neurotransmitter disorder as the cause of depression is a little bogus. So just the simple model, so we're going to have to modify that. Are we happy with the medical establishment's definition of depression? Is that DMS-5 the correct Bible to use? Is that what we want to agree on? Does the definition remain the same for different cultures in different times? When something is medicalized as a disease, is that an imperative for treatment? So think of the word dis-ease. Dis-ease. Uncomfortable. Comfortable? Uncomfortable. Dis-ease. But does it require a medical problem or definition for treatment? The standard Bible for the medical profession in psychiatric illness then has been this Diagnostic, Statistical manual. And they've come out for different years all the way along. Danny Pine, he was at the Grinell College, had a great lecture on this, and graciously let me use this slide. Well, an interesting thing happened that we'll talk about. When should someone's behavior be labeled and classified as a disease? And who should determine that? I think that's a very germane point here. When is a behavior considered deviant, abnormal, or wrong? What about child's behavior in the doctor's room? You have a little kid comes in there, a little toddler, and two kids. One little kid comes in and just sits there like this during the whole time, sits in the chair on mommy's lap. The other kid is in there messing with my tools, getting all this stuff out. I'm trying to get back here. Okay, two different behaviors, different kids. In our culture, in Japanese culture, the little kid that's like this, that's the correct, right behavior. This other kid is screwed. I personally, although I don't like the kids taking all my tools, I'd much rather have a kid that's exploratory and wants to look into the world than some kid that's just sitting there as a bump on the log, you know, looking at me like this. But you see the difference of culture? Sex differences for behavior. We find out a baby, I watched it in the nursery all the time, we find out a kid's a boy or girl, how roughly they're handled, how they're talked to. The girl is talked to totally different than the boy. Oh, the boy is more thing, and more jostling around. So we have a conscious and unconscious difference of how we treat our kids. Looking people in the eye, shaking hands. Is that a cultural thing? Darn right. Some cultures, you don't want to shake. Wow. You look them in the eye, otherwise you don't. See the importance of culture here? Men wearing skirts. If you were in Greece or Rome, or in Scotland, skirts are the preferred way to go. Medically, they're the preferred way to go. We're supposed to be cooler down there. But if men wear skirts now, big social football. But what about women? The things that's changed. They can wear men's things now. Pants, suits, everything, but no, we're not that far. Same with jewelry. When I was a kid in high school, if you wore an earring in your ear or a pink shirt, oh boy, you got ostracized. I mean, you got hammered. So within this time, all of a sudden that's changed. And extramarital sex. I talked about Confucius. In the Confucius times, if you were a male and you had a concubine, that was, you know, you had a concubine. That was cool. That was accepted. Some of the kings of England, the higher aristocracy, they always had women on the side. They were okay for that class. Homosexuality. What if you were back in Greece?
Oh.
It was fine. What if you were in a Mideast Arab society? What about different times in this country? Committing suicide. Does that have a social stigma? Yeah, very much. Religious so. Sometimes you're not going this way if you commit suicide, or you're not be buried in our cemetery if you committed suicide. So that's very, very important. In the Middle Ages, if you committed suicide, your family lost all of their property. That was an automatic thing. So if you committed suicide, they come in and the government of people, the feudal, they got all dibs on all your stuff. On all your property, all your pigs and everything. So you committed suicide, you had some serious, it's very different. Was suicide illegal in sometimes? Like, you're going to go to jail for killing yourself? Like, but, you see, the legal thing on suicide. Grief. When is grief pathologic? When should we call it a disease? When does it go into just normal, and where does it go into... It's a disease or pathologic and has to be treated. Good questions. So what defines? Context is key. You have to take the behavior, what's going on, and put it in context. And I'm saying temporal context, social context. So our whole depression of the discussion here, we're moving from biochemicals to a little broader model, which I hope you see. Ira Glass, 1973, he did this on the radio in 2002. Sexual deviations. This category is for individuals whose sexual interests are directed primarily toward objects other than people of the opposite sex. So, if you have anything from fetish to males or sexual sadism, any of those things are considered, until 1973, were considered diseases. So basically, this is when the American Psychiatric Association no longer had homosexuality as a disease. Their gavel came down and they said, we're not going to consider that a disease anymore. Think what was going on in the 70s and the 60s. If that same thing vote came up today, in the group of psychiatrists deciding when they did this manual, I'm not sure that they would have declassified that as a disease because of the political atmosphere and how many people are from the right or whatever, putting pressure on stuff. So the definition has to be put in the social context. No longer that's considered a disease. If it's not a disease, do we have to cure it or fix it? By definition, no. So you see the importance of deciding whether something's a disease or not? That's really important. Because if it ain't a disease, you ain't got to fix it. Now, are there other views of disease? Yes, obviously. So there are other people say, well, we don't care what the doctors or whatever say. We still consider a sickness because of blah, blah, blah. So there are other definitions of what we use as disease. The NIH won't follow Psychiatry Bible anymore. So on some of their things, they're saying, well, we're not going to just go along with this. This is the National Institute of Health. There's always a well-known solution to every human problem. Neat, plausible, and wrong. I like that quote. So, whether it's global warming, whether it's this or that, and it's kind of like that. Yeah, I always love this quote. Yeah. Do we understand the disease? Should be clear now that a simple neurotransmitter model is not the whole story. Why do women have twice the incidence of depression as men? Could it have anything to do with their hormones? Women? What did you think? What does the rest of the hormone system, such as cortisol, thyroid, and the sex hormones, have to do with depression? What about the immune system? What about the effects of light, sleep, diet, etc., etc.? Cortisol levels vary with depression. Cortisol is stress hormone. It's made in the adrenal gland. And so when we get stressed, it comes up, and it's a pretty powerful hormone goes all through our body. 3 separate events: rise in cortisol, a stress hormone, which is the stress hormone, a decrease in serotonin receptors, and depression are all coincident. What's the relationship? So there's something going on with the serotonin receptors and cortisol. The normal diurnal pattern is disrupted in depression. Normally, when you're sleeping and you wake up in the morning, your body's making this, is starting to peak up on your cortisol levels. That's what gets you out of bed, gets you going, and gets you feeling good. What about depressed people? They start out low in the day, and as the day goes on, it goes higher. So they feel better later in the day and in the evening. Talk to most depressed people, mornings are the worst time. And if you measure their cortisol and blood levels, it's different. The brains of human suicides have high levels of cortisol releasing factor, and their adrenal glands are often hypertrophied. So chronic stress and suicide. Stress a rat, and you'll have high levels of stress hormones and screwed up serotonin receptors. So it isn't just what we think about it, because this happens in rats. But you give the rat an SSRI, and his cortisol levels eventually normalize. Isn't that interesting? So here's rats, you stress them out, but then you give them some Prozac, and not only do their levels, their serotonin levels change in the brain, but their cortisol levels come down. Really interesting. Baboons and air traffic controllers. Oh, wait, come on. Chronically stressed baboons tended to become paranoid and would fight over a banana next to a tree covered with them as violently as they would if their own life was involved. So you stress an animal and they act different. You stress them enough and they become paranoid. What about people? You've got high cortisol levels in them, they're stressed a lot. Do they start becoming a little paranoid, seeing the things other people are doing? Air traffic controllers who were psychologically healthy, two groups, had an exact correlation between the extent to which they were being overworked and their levels of cortisol. So you got these air traffic controllers and you say, hey, can I check your stress level, your cortisol all the time? Yep. And you find out that, yeah, it goes up. They get more work and their levels go up. That's normal physiologic response. But those who were in poor emotional health, down here on our line, had their cortisol skyrocketing and peaking all over the place. It wasn't following any normal pattern. Who do you want bringing your plate in? The guy with emotional health who's working too many hours? Or the emotionally unhealthy person who's working too many hours and is going to overjump and go over there? You see the difference? This is real world stuff here, because we can measure this. Also, they then felt stressed about everything. This stress hormone, once it's going, you feel stressed not just about your work, but you're stressed at home, and you're stressed about this, and the food, and the seating arrangement, and how hard this is on your rear end, and all that. And that itself was depressing. So feeling stressed and seeing everything's depressing, that's depressing, but what did I say depression does? Causes more stress, so you see how it's a vicious circle. So chronic, repeated stress seems to be a very strong etiological factor and related to this. Chronic stress. If you have stress for too long, you even start destroying neurons in the amygdala part of your brain and the hippocampus, the very neurons that should regulate the feedback loop turning down the cortisol after the stress is over. So you do this long enough, you make anatomic changes. Depression in women. Gee, women have increased incidence of depression, puberty, postpartum, menopause, and PMS. Is that true?
Yes.
Damn right it is. Is that just from serotonin receptors? Don't think so. Studied 7 countries, 10,000 women. Also found that most depression risk factors, substance abuse, life stressors, are more common in women and have a greater effect than in women than in men on major depressive risk. So women, your hormone systems and brains make you more susceptible to this. It's a complicated system. Stress, all these hormones, different glands in your body. And what about obesity? All these other things are going on, can make chemical changes, leptin, and some of the outcome of this is become obese. But it all goes back to this constant interacting of these different things. What about men? Are we different? Yeah. What about depression in men? Any generalizations you make? Are we the same as depression women? Same symptoms? Do we present the same?
No.
She's saying no.
And it's not socially as acceptable either.
No, it's not socially acceptable. Right. Unfortunately, men are far less apt at recognizing our own symptoms in women. A man is more likely to deny his feelings, hide them from himself and others, try to mask them with other behaviors. The three most common signs of depression in men are physical pain. Sometimes it shows up as physical symptoms, backache, headache, sleep problems, sexual dysfunctions that don't respond to normal treatments. Anger, key. A lot of men come in, they're really angry and upset. And I go, what are you depressed about? And they go, I'm not depressed, I'm angry. It's the same side of the coin. Depression and anger, in my experience, it's just heads and tails, but it's the same point. Anger, irritability, sensitive to criticism, road rage, short-tempered. Some men become abusive, controlling, verbally, physically abusive to their wives. Reckless behavior. A man suffering from depression may start exhibiting escapist or risky behavior. Dangerous sports, driving recklessly, engaging in unsafe sex. Might drink too much, abuse drugs, gamble compulsively. So these are where males try to mask it down because men aren't, we're supposed to be strong, we don't have emotions. So we hide it very well and do these other things, which eventually get us in more trouble. So differences between males and female depression, this is just tend to. It's not, women tend to blame themselves. Oh, I'm inadequate, I'm a bad mother. Men blame others. Feel sad, apathetic, angry, irritable, anxious and scared, feel suspicious and guarded. Avoid conflicts. Oh, I don't want to upset anybody. And go out there and get in your face. Feel slowed down, restless, agitated, trouble setting boundaries, need to feel control. Find it easy to talk about self-doubt and despair. Man, you know, it's weak to admit self-doubt. You don't go in the locker room and say, oh, I feel, talk to the guys at work, no, I feel out of self-doubt and despair. Use food, right, women, friends, and love to self-medicate. Men use booze, TV, sports, and sex to self-medicate. Do you believe that or not? I think that's damn true. So there aren't a lot of doctors come to my office and say, Doctor, I've been depressed, and I've been introspective for a couple months, and I think I have depression, and I'd like that antidepressant to advertise on TV that doesn't screw up your sex life. Because a lot of them do. So a lot of men won't take it because that isn't going to work. Seriously, or they start it, and it interferes with their sexual performance, they throw those in the basket real quick. So if you don't ask, you don't find out. Why do we even have moods? Good question. Why do we have moods and emotions in the first place? What's the evolutionary imperative? Baby care. Got that cute little baby coming out. Social stability in communities. Caring for one another. Watching out for people. Is there anything worse than ostracism? You've been kicked out of depression as far as you can think of. Think of kids, adolescents that are kicked out for whatever reason, going out of their high suicide rate. So being very important. The genetic screw up, rank and pecking order. Are our primitive brains out of step with modern society? We have a reptilian brain, we have a limbic system, and a neocortex, all evolved over many years. The primitive brain down here is self-preservation, aggression. I'll call it instincts. The higher brain, the limbic system, came later in evolution. It's emotions. And the rational brain, the higher, which affects mood, is the intellectual tasks. So let's just summarize this a little bit and then we'll wind down. So a wasp, for example, when it lays its eggs, it doesn't care about the eggs, it just lays the eggs. There's no emotion, the bobcat, right? Garter snake, yeah, it has babies, they're like, but it doesn't watch them, it doesn't take care of them. Once they're born, they're out of there. There's no mother bond, you know, it doesn't need to be. Praying mantis, even worse. Not a lot of spousal devotion here because if you didn't know it, after the male mates with the female usually eats the male's head and devours him right after copulation. So, not a lot of family structure there. And mother's advice to the babies. Of course, long before you mature, most of you will be eaten. So there's not a lot of teaching going on in insects at this primitive brain level. We don't need it, right? So why do our office, we are obsessed with the decoral eagles. We have them on there all the time. They're cool. We watch them. It's great. Millions of people are watching the recording. Goes, why? Why? Mama and daddy. And they're the little babies. Why do we watch it? What's it do emotionally? Makes us feel good. And what emotions do we see in them? Caring, love, mother and the dad taking times, going on the front, one stays on the nest. So we're seeing emotions that they are showing. So animals and birds show emotions. They have loss, grief, yes. And that's what we like about them all we get. We really get touchy-feely when we see this cool little eagles. Animals, dogs, with all their little puppies, same thing, right? Chimpanzees, the same. But their mamas have to have them a lot longer, don't they? Than the other mammals. And of course, moms and babies. So what's the first emotion a baby feels when it's born? What would you feel when you... Well, is it a pleasant emotional experience? No. So the baby's first experience is not good. That's the first emotion that all of you and all of we have had. What's the mother's first emotion usually? Relief. And then when she sees the baby?
Joy.
The opposite of depression. Love. Happiness. Ultimate happiness. So that's emotions. Correct? Chip babies better behave than the human cousins. It's tougher to calm down. Chips calm down pretty quick. Babies sometimes just keep crying and crying and crying. It has to do with the fact that the chimp babies mature more quickly, making them better behaved children. So the idea of how long you have to be raised by your parents is going to be very important in this depression. And elephants, of course, bond for a lifetime, their families, and the social structure. And we'll talk later about if elephants know they're going to die or how they think about death. Okay, so let's summarize this now and tell you where we're going to go next. So then, what contributes to depression? How much and why does it matter? How much is genetic? How much is how we were raised by our parents? How much is determined by our culture? How much is determined by the world and what happens to us? Finally, how much can we control? Ultimately, how we answer this determines how morally responsible we should be held, I think. Should we feel more sympathy for someone who is depressed if we label it a chemical imbalance and is genetically predisposed, and less for someone who has behaved badly and made poor choices? Aren't we all in this? Is that important? Wondering? When should a person get sympathy, and when should I get a kick in the butt? I mean, don't we have this ambivalence? Sometimes you feel sorry for them, but sometimes it's like... All right? So the question is, we're going to lead into what the difference is, and when the one that is appropriate and when the other isn't. Genetics, we all come partly wired out of the womb. And identical twins are different, but they're pretty much the same. But 70 to 80% of the time, if one twin is suppressed, the other one gets suppressed, even if they were raised separately. So there's a big genetic component. Right? Environment versus heredity. Again, 76% of the time, one twin gets it, another one's going to get it. Right and left brain. We're going to find out that people are more right brain active, and more left brain active. And that makes a big difference. It makes a difference in a baby. And in other words, there's an experiment which I'll show. Certain babies, you leave the room, and some of them go nuts. They cry, they go berserk. They have a activated right brain more. Some baby, you leave them, and they just explore the room. That's different. Their brains are wired differently. We're going to find out later, if I show different people a picture of a horrible thing or a nice thing, and we watch your brain, You react differently and for different periods of time. So some person, if I show you a horrible picture here, your brain goes through all these chemical things and then it dies down quickly, the effects of it. Some of you, when you see that same picture in here, your chemicals go up and stay up for a long period of time. So we can just measure it. So see, that's pretty tough biology stuff. And then the last thing, of course, is what does life do to you? You have a loss, you have a job promotion, you don't, all these things happen. Your spouse leaves you, your kids get in trouble. Those are all other events. So the question is, what can we control and how much? So the next class, what I'm planning on doing is continuing on this to have a model that involves biochemical, social, and spiritual. And I want to make it more concrete and tell you exactly about 7 or 8 things that can be done specifically and how you do those things. It's going to come down that you can control what you're thinking in here controls, I'm going to say 70 to 80% of where you're going to be on this emotional line. The happiness comes from within, not without. And why people are always dealing with what's out there, what other people are doing, what's happening, and why you're screwed if you're going to follow that model. That no, it comes from inside. But I want to show you how. So just saying like, oh, live every day as if it's your last, or make every day count, those platitudes are nice, but we need some specific, okay, how am I going to do this? What specific things? And that's what I want to develop next time. Your homework assignment then, for next time, didn't think you're going to get out of that, did you? It's going to be simple and fun, and you'll see how we do it. I want you to write down 5 things, and this will be back to an email, that you value in your life, the most important things in your value system. So most of you haven't done this before, and I find that's very important in dealing with people with depression, and you'll find out why. What do you value? I value lots of money, niceness. I value my intellectual capacity. I value health. I value my animals. I don't care. What do you value? And they don't have to be exactly in order, but give me your top 5. And if you can put a priority for it. And the next thing is, when people come into my office for a depression consult sometime, I say, I'm the fairy god doctor. And I don't get any costume on, but I say I'm the fairy god. And I will grant you, Karen, 3 wishes. You can't ask for more wishes. You only get 3 wishes. What would you wish for?
I have to answer that.
No. You do, you're not right now. And I want you to write down.
Make an appointment.
Well, yeah. But again, if you have 3 wishes, then I can make you 3 wishes. I don't know, make the Iowa weather different. Get a different political system. I don't care. But 3 wishes is all you got. So your values, 3 wishes. And you're going to go, well, what's this have to do with it? Well, I'm going to show you that a lot of people, particularly younger generation, are screwed up and depressed, not because their brain chemicals are off, but they don't have a value system. They don't have a compass for life. They don't have an anchor. They don't have anything to put there, so they are trying to just do things that make them happy in the moment, short term. So it makes them feel good and feel happy, and they keep doing that. That's the secret to happiness. And I'm saying, I think this emotional stuff is in values we're going to factor in. And lastly, we're going to lead into, if it's what my brain's thinking, how do I control what my brain's thinking? I can't help it. It just thinks worried about my kids. Or I worry about my husband's health. Or I worry about this. Or I worry about the weather because I got to get my corn planted. And, okay, all this worry stuff. Well, I can't control that. And I'm going to say, yeah, you can. But I got to show how you can control that. And the key is going to be, I'll just throw out the word, is mindfulness. And how you can cultivate mindfulness to control your wild mind. So that's a preview of coming pressures. So we're going to get your money's worth here. But with that, let's join in. Thank you very much.
for a lot more wishes. Remember to turn your cell phone back on, the key coil off, and change your calendar to include May 21st for the last portion of JR. See you next week.